Okay. Hello everyone, how are you? I'm Shaimaa Mohamed, a fifth year medical student.
And I'm Safia Elhassan, a fourth year medical student.
Okay, and today we're going to be doing the neuropathology practice question session or review session. I'm going to take a few lectures, Safia is going to take a few lectures, and then at the end, we're going to have like a random compiled question session, basically. Okay, so let's start with the first question. Also, if you guys have any questions or anything, you can just send them on chat. And also when you can send your answers on chat, or you can unmute yourself if you wish. Like, so a 55-year-old man visits the physician because he has had a foot ulcer for 2 months that has not healed. Physical examination shows a 2-centimeter shallow non-healing ulceration of the left medial malleolus. There is a symmetric decreased sensation in the distal region of the lower extremities. The patient has a history of multiple UTIs resulting from difficulty in completely emptying the bladder. He's impotent. Which of the following pathologic findings is most likely to be present in the peripheral nerves? So most of you guys are saying E. Why are you saying E? What does the patient have as a disease? Yeah. So these are signs of diabetes, the recurrent UTI, the non-healing ulcers. So E is the correct answer. Sorry. E is the correct answer, axonal neuropathy. Why is it not Wallerian degeneration? So Wallerian degeneration would usually be acute secondary to, for example, transection with stabbing with a knife or something like that. It's not inflammation. Nothing about this is acute inflammation, onion bulb formation, you have to know. And endoneurial lymphocytic infiltration, that would also be a sign of inflammation, maybe GBS, but it's not here. Okay, so we have here the different types. So this is the normal nerve. We have the cell body, the nerve, the myelin sheath, and the muscle. Okay, in Wallerian degeneration, as we said, there would be some sort of transection or stab injury, some acute injury that happened to the nerve. So what happens is that the distal part to the injury, so this is the proximal part, the distal part starts degenerating, and then macrophages come and eat it and basically dissolve this part for Schwann cells and for the cell to produce a new axon and new myelin sheath. And because the nerve supply has been cut to the muscle, you can get muscle atrophy. And also, if you see something here, this is the normal nerve, and it has something called Nissl buddies, which are basically just rough endoplasmic reticulum that's been stained. When there's an injury and now the nerve needs to grow new axons, it's going to basically disperse. The Nissl buddy is going to disperse, and that's why you don't really see this color here anymore. So this is called chromatolysis or central chromatolysis. Okay, so it happens in Wallerian degeneration. In demyelination, the axon is left intact. Only the myelin is it's abnormal. So what happens? The Schwann cells can really take care of that. So there's no central chromatolysis because the cell body itself is not working, and there's no muscle atrophy because there's still innervation to the muscle. Here in distal axonopathy, it starts from here, usually due to chronic diseases like diabetes or something. The nerve damage is gonna start distally, and then it's gonna go back. This part is gonna get damaged, and this part, and this part. So this is the axonal neuropathy that we saw in that question. Again, you're going to have atrophy and also central chromatolysis. Okay. So let's see here. Just tell me with like yes or no. Does Wallerian degeneration have central chromatolysis?
Don't worry, disappears when I can't open the chat box and
Okay. So does Wallerian degeneration have central chromatolysis? Yes. No. Yes. Segmental demyelination? Oh, no. Distal axonopathy? Yes. Okay. So in the exam, the doctor might just get you a picture of these. Okay. Stocking glove sensory loss. Where do you think that will happen? Oops. What is going on? Will it happen in Wallerian degeneration? No. Yes, in axonal. Okay, axonal sprouting. Where is it? Axonal sprouting is basically new axons coming out of the proximal part to build the new axon. So where would that be, Yani? After Wallerian? Yep. So it's after Wallerian degeneration. There is Wallerian regeneration, which is basically the process by which the new axons form. So that's axonal sprouting, so it's not going to happen in the others. Where do you think you're going to find low amplitude of the nerve in conduction study? Is it when there's axonal damage or demyelinating damage? Demyelinating, yes. And sorry, low amplitude is in axonal, and then low conduction velocity, low velocity is going to be in the demyelination. Low amplitude is going to be in the axonal, if there's damage to the axons themselves. Okay, good. Next question. A 40-year-old man had an because the axon itself is damaged, so the nerve impulse itself is not going to be as strong. But in demyelination, the nerve is intact. The issue is with the myelination. What does myelination help with? It helps with speed. So the velocity, the speed is going to be low. So it's going to be the same amplitude, but slow. That's because there's no myelin. In in axon damage itself, you're not going to have enough strong impulse because the nerves themselves are damaged. That's why there's low amplitude. Okay. Does that make sense? Okay. Now, next question. A 40-year-old man had an influenza-like illness for 1 week. A few days later, he experienced a rapidly progressive ascending motor weakness that required intubation and mechanical ventilation. On physical examination, he is now afebrile, has 3 out of 5 motor strength in his extremities. Lumbar puncture is done, yields clear, colorless CSF fluid, normal pressure. The CSF has slightly elevated protein concentration, but normal glucose level. And the cell counts with only few mononuclear cells. The patient recovers in 3 weeks. If lymphocytic infiltrates were seen in the peripheral nerves along with segmental demyelination, what would be the most likely diagnosis? Okay, all of you are saying A. That is correct. Guillain-Barré syndrome, GBS. Why is it not multiple sclerosis? Yani you're going to take it later, but multiple sclerosis is central. This is peripheral nerve. Amyotrophic lateral sclerosis would be both upper motor and lower motor neuron, and it's not demyelinating. It's the neurons themselves are dying. It's not shingles, and it's not B12 deficiency. What does B12 deficiency lead to? So GBS can be GI and also upper respiratory tract infection. It doesn't have to only be GI. Yes, subacute combined degeneration is caused by the B12, which is the spinocerebellar, spinal, and the dorsal column degeneration. Okay. So GBS is, like we said, it's post-infectious immune-mediated neuropathy. So there's going to be demyelination post an infection, which can be GI or it can be upper respiratory tract. In our case, the patient had upper respiratory tract infection. And it's symmetric ascending. So it starts from the bottom and goes up and it's flaccid. It's not spastic. Spastic means it's upper motor neuron. So it's flaccid. Result of molecular mimicry, which means that you get an infection, either GI or upper respiratory tract infection, and the immune system produces antibodies against them. These antibodies can also attack the myelin sheath because it has something similar to the antigens of the bacteria or the virus. So what's one common bacteria and one common virus, that can cause GBS? Campylobacter jejuni, bacteria. Virus, yes, CMV, perfect. Okay, so CMV is like the most common virus, and Campylobacter is really the most common bacteria. In CSF, you're going to find something called albuminocytological dissociation. What does that mean? If you see here, the CSF was elevated protein, which is usually albumin, but the cell count was normal. So that means, yes, exactly. So high protein, low cells. Okay, perfect. What is the most common inherited polyneuropathy? Yes, صح. Perfect. Charcot-Marie tooth disease. The other ones I don't really know, but I hate content. So Charcot-Marie tooth disease is the most common polyneuropathy. Okay, next question. A 76-year-old male had sudden weakness in his arm and face with slurred speech that started 16 hours ago. What findings would you expect to see in his brain if a sample was taken? Okay, so someone is saying, oh, this person is saying D. Anyone has any other answer? D, okay. Yes, صح. Perfect. D, red neurons, which usually appear between 12 to 24 hours. After that, you're going to have the infiltration of the neutrophils and whatever cells. And then after that, you're going to have the scars. After like around 2 weeks, you're going to have the gliosis and stuff. Okay. So now I'll just want you to match the number with which picture. Okay. And then what's it called? Bismillah. And tell me what you see, okay? So the most important histopathological marker for CNS injury, is it 1 or like A, B, C, D? Most important histopathological marker for CNS injury. Okay, so D can be a correct answer, but there's something even more correct here. Yes, okay, so it's this one. Can I see? Yeah, it's this one where you see cystic astrocytes, which is gliosis. Okay, so these are astrocytes. Gliosis is the most important histopathologic marker for CNS injury. It can be anything, and you might find gliosis. Okay, which one of them is of mesoderm origin? Okay, so I'm saying this 3. Okay, anyone else? And why do you say 3? What do you see? What is this called? Okay. WBCs. Okay. They are kind of WBCs. They're not microglia, okay? So these are microglia nodules, and microglia are cells that originate from the mesoderm. Okay. You usually find them in CNS infection or something like that. Which one is caused by acceleration deceleration injury? 1, what do you see in here? No, okay, so this is not the cell body. What is caused by acceleration deceleration injury? What's the issue? صح, it's diffuse axonal injury, صح? Yes. So these are accents. So these are axonal spheroids. They kind of look like central chromatolysis بصراحة, بس oh my God, I'm gonna kill Campbell. But these are axonal spheroids, okay? In diffuse axonal injury. And lastly, clumped intermediate filament proteins. What are these? Placental fibers, which can be seen in either tumors or they can also be seen in gliosis. And what is the intermediate filament protein that's clumping up? What's it called? Short form for, yes, GFAP. Perfect. Okay. Yes, GFAP. So but in like a quick summary of cerebral edema. So we have vasogenic and cytotoxic. Vasogenic from the name vaso, from the vessels. So there's a problem with the vessels. They got injured, they're leaking. So blood-brain barrier, there's dysfunction of the blood-brain barrier. The fluid is leaking and it's leaking between the cells. So it can be caused by tumor, stroke, and many stuff. In cytotoxic, there's injury to the cell itself. So the cell membrane is injured, the cells swell up, the fluid is accumulating inside the cell, which can be caused by toxins or ischemia. Okay, I think that's the end of my part for now. I'll let Safia share her part.
Can you guys see my screen?
Yep.
1 second. Okay, so we'll start with a question. A 55-year-old man has experienced headaches for the first time in his life, beginning 2 months ago. He comes to the emergency department following a generalized tonic-clonic seizure. On physical examination, he has weakness on the left side. An MRI of his brain shows a large, irregular 6-centimeter mass in the centrum semi-ovale of the right cerebral hemisphere that extends across the corpus callosum. A stereotaxic biopsy of the mass is done and microscopically shows pleomorphic cells positive for glial fibrillary acidic protein, or GFAP. Molecular analysis shows abnormalities of TP53 and platelet-derived growth factor alpha. Which of the following neoplasms is he most likely to have? Okay, everybody is saying B, and that is correct. The answer is glioblastoma. So what were some of the clues that helped you guys decide that it was B? Crosses corpus callosum butterfly tumor, TP53. Yes, exactly. All of those are correct. So let's just quickly go through some of the other options. Diffuse large B-cell lymphoma, that's usually seen in what type of patients? Okay, someone is saying, yes, immunocompromised. Diffuse large B-cell lymphoma is typically seen in immunocompromised patients. Hemangioblastoma, that wasn't really covered in your lectures, but it's related to a disease called VHL disease. And medulloblastoma is seen in which type of patients? Yes, children. And why did you guys rule out pilocytic astrocytoma? Not that dangerous? Okay, yes. Pilocytic astrocytoma, grade 1, typically seen in children and negative to TP53. All of that is correct. Okay, what would it look like on histopathology? A, B, C, or D? A, yes. That is correct. This is what a glioblastoma looks like, and we will talk about this in more details in a bit. Okay, a 10-year-old boy has persistent headaches for the past 3 months. On physical examination, he is afebrile, he has an ataxic gait and dysdiadochokinesia. CT scan of the head shows a 4-centimeter cystic mass in the right cerebellar hemisphere. Cerebral lateral ventricles are enlarged, a lumbar puncture is done, the CSF protein concentration is elevated, but the glucose level is normal. Neurosurgery is performed and the mass is removed and sectioned. On gross examination, the mass is a cyst filled with gelatinous material. The cyst has a thin wall and a 1-centimeter mural nodule. Microscopically, the mass is composed of cells that stain positive for glial fibrillary acidic protein and have long hair-like processes. What is the most likely diagnosis? Okay, so everyone is saying A. Yes, that's correct. This is an astrocytoma. And what does it look like on histopathology? A, B, C, or D? B, yes, B is correct. So let's start with a brief introduction on CNS tumors. So CNS tumors can be composed of neuroglial cells. So these are the supportive cells of the CNS, and they include astrocytes, oligodendrocytes. They could be made of neuronal cells, which are the actual neurons. They could be embryonal cells, which are the cells that you would see early in development before they differentiate, or they could even be meningeal cells. They could be classified as intraaxial versus extraaxial. So intraaxial means that they're in the or within the brain parenchyma, while extraaxial means they're outside. So one thing that's very, very important for CNS tumors is the molecular classification. So it's very important to kind of look at whatever underlying genetic mutations there are. That will help you diagnose the kind of tumor that you have. It will tell you, or it will also help you determine the kind of treatment that you want to use for it, and it will also help you determine the prognosis. And the best way to diagnose CNS tumors is through histopathology. So let's start with astrocytomas. Astrocytomas are the most common type of glial brain tumors. So that's the classification in which astrocytomas, oligodendrogliomas, and epidenmomas fall under. And there are 4 grades, and these grades are basically how well differentiated and kind of the histopathology and how aggressive the tumors are. So grade 1, which is pilocytic astrocytoma, this is the most benign one, typically seen in children, and it's located in the cerebellum. Because it's located in the cerebellum, it's going to affect cerebellar functions. So patients that have pilocytic astrocytomas will typically present with things like clumsiness and ataxia. And then you have diffuse and anaplastic astrocytoma. So once an astrocytoma has been classified as diffuse, it can no longer be pilocytic. It has to be grade 2 or above. So with a diffuse astrocytoma, it will be diffuse. It will have some mildly increased cellularity, but it will not have any mitosis or necrosis. With anaplastic astrocytoma, you have increased atypia compared to grade 2, but again, you have no necrosis. Once you start to see necrosis and microvascular proliferation, this is when you know you have a grade 4 tumor or a glioblastoma. Now, as for the staining, all astrocytomas are positive for GFAP. In children, they are most likely located in the cerebellum, but in adults, they are located in the cerebral hemispheres. And so adults will present with things like seizures. So this is grade 1. What are some of the histological features that you guys know about grade 1? Or you can see it here, but just tell me what you know. Yeah, rosenthal fibers. Yes, so grade 1 will present with cystic spaces. So cystic spaces are these little fluid-filled spaces, and they contribute to the overall cystic appearance of the grade 1 tumor, which we'll look at in just a minute. You also have these rosenthal fibers. These are the hair-like or corkscrew-shaped processes, and they're very bright pink. And then you also have eosinophilic bodies or granules. So this is what it looks like. And it has a very cystic appearance, and that's due to the presence of microcysts in the histopathology. And here's an MRI of what it looks like. So I want you guys to appreciate its location here, which is in the cerebellum. And that's because this is juvenile and pilocytic astrocytoma. Okay, and this is grade 2. So grade 2, as compared to the rest of the white matter in the brain, it has increased cellularity and increased cell density. However, mitotic activity is rare. That is a feature that you would most likely see in grades 3 and grades 4. So this is what grade 2 looks like. When you look at it here, it may appear that it's well demarcated, that you can map out the borders of the tumor, but it actually infiltrates into the surrounding tissue, and that's why it's a diffuse tumor. This is grade 3. So here, grade 3 and grade 4 are actually classified as high-grade tumors. Here, this is where you will start to see the nuclei displaying atypia, which is when they start to have different shapes and different sizes. The color will also be a bit darker. You will have pleomorphism of the cells. So all of the cells are going to start to have different shapes. The nuclei will be darker, and you will start to see mitotic activity here. Like, for example, here, you can see this nucleus splitting and this nucleus splitting here. So this is really where the cells start to get uglier. And then this is grade 4. So grade 4 has a very distinctive feature, which is pseudopalisading. Do you guys know what pseudopalisading is? Yes. So you have a central area of necrosis that's surrounded by this dense ring of tumor cells. And again, what's very important for grade 4 is the presence of necrosis and endothelial proliferation. And here's what it looks like. So it has this yellowish appearance, and that's as a result of the necrosis. It also has hemorrhages. And here's what it looks like on a CT. So it has this ring enhancement. It's a large size, it's irregular, and the ring enhancement, all of this makes it very, very suspicious for malignancy. Okay, now on to the molecular mutations for every single type of astrocytoma, starting with pilocytic astrocytoma. So these are characterized by germline mutation in the MAPK pathway genes. For diffuse and anaplastic astrocytoma, memorize them together because they have the same mutations, which is IDH1/IDH2 as well as TP53. For glioblastoma, it's a little bit more complex. When it comes to the molecular mutations, there are two different groups. There's astrocytoma grade 4, and then there's glioblastoma. So the astrocytoma grade 4, that is if you have a mutation in IDH1 and IDH2. However, if there is no mutation in IDH1, IDH2, as well as another gene called histone 3, then it would be called a glioblastoma. So as for the prognosis, as you guys mentioned correctly, pilocytic has a good prognosis, and then it gets worse and worse as you progress through the different grades. And here is some extra information about each of the types of tumors, which we covered when we were looking at the images. Okay, what kind of tumor is this? Yes, what type of glioblastoma? Yeah, this is a butterfly tumor. So a butterfly tumor is a very, very aggressive form of glioblastoma, and it basically spreads across the cerebral hemispheres through the corpus callosum. So the corpus callosum is very dense. So it would really require an aggressive type of tumor to be able to actually cross through it. And another feature of this tumor, and although this is very rare, is that it can actually metastasize outside of the CNS through the CSF. And this right here is a gliomatosis cerebri. So gliomatosis cerebri is, again, another form of a very aggressive type of glioblastoma, and it spreads all throughout the brain. So here you can see that it covers almost through the entire cerebrum. This picture was not in your slides. I just added it to show you guys what it looked like. Okay. A 16-year-old male presents with a history of focal seizures for the past year. Neurological examination is unremarkable. MRI reveals a well-circumscribed cystic mass with an enhancing neural nodule in the temporal lobe. A biopsy is performed, and histopathology shows pleomorphic cells, abundant reticulin deposition, eosinophilic granular bodies, and GFAP positivity. No necrosis or significant mitotic activity is observed. What is the most likely diagnosis? A. Glioblastoma multiforme, B. Pilocytic astrocytoma, C. Pleomorphic xanthoastrocytoma, D. Medulloblastoma, or E. Oligodendroglioma. Okay, so I'm seeing some B's and I'm seeing some C's. The correct answer is actually C, pleomorphic xanthoastrocytoma. However, I understand why you guys picked B. That would be the second best choice, but there are some things that can help us narrow down the diagnosis. The first one is the age of the patient. He's 16 years old. Typically, pilocytic astrocytomas would present in younger children. The second thing is how he presented. So he presented with focal seizures. How do pilocytic astrocytomas usually present? Ataxia, yes, cerebellar issues, exactly. But pleomorphic xanthoastrocytoma is located in the temporal lobe. That's why it causes seizures. The enhancing neural nodule, so yes, this is similar, a similarity between the two. Another thing that's unique for pleomorphic xanthoastrocytoma is the presence of pleomorphic cells and abundant reticular deposition. And GFAP and eosinophilic granular bodies can be seen in both. There are a lot of similarities because PXA is in fact a type of astrocytoma. So pleomorphic xanthoastrocytoma is a grade 2 tumor, so it's relatively low grade, more common in children and young adults. In histology, you would be able to see pleomorphic astrocytes with xanthomatous cytoplasm. So what does this mean? They have a very distinctive shape, which we'll look at in a minute. And xanthomatous cytoplasm means that, yes, it has the presence of lipids and the presence of fat. Eosinophilic granular bodies, similar to astrocytomas, chronic inflammatory cell infiltrate, and abundant reticular deposits. So these are fibers that we'll be able to see in just a minute. So the location is, again, in the temporal lobe. It's positive for GFAP, and that's because it's a type of astrocytoma, and it has a good prognosis with complete surgical resection. Often presents with seizures because of its location. So this is what it looks like. This is the pleomorphic cell. It has abundant reticulin, which are these fibers that you can see here, GFAP positivity. And one thing that's very important for pleomorphic xanthoastrocytoma is that people sometimes think that it's a very high-grade tumor just because it has a very ugly shape or it looks very ugly. But to help you rule that out, it does not have significant mitotic activity or necrosis, which is specific for grade 4. And in fact, it has a relatively good prognosis. Okay, is this clear? Did you guys get why it's not pilocytic astrocytoma and the differences
Yeah.
between the two? Okay. A 40-year-old man has been experiencing headaches for the past 6 months. He had a seizure 1 day ago. On physical examination, there are no remarkable findings. MRI of the brain shows a solitary circumscribed 3-centimeter mass in the right parietal centrum semiovale. The mass has small cysts and areas of calcification and hemorrhage. Neurosurgery is performed and the mass is removed. Microscopically, the mass consists of sheets of cells with round nuclei that have granular chromatin. The cells have a moderate amount of clear cytoplasm, and they mark with GFAP by immunohistochemical staining. The patient receives adjuvant radiation and chemotherapy, and there is no recurrence. Which of the following molecular markers is most likely to be found in the cells of this mouse? E. Okay, so what do you guys think the tumor is? Oligodendroglioma. Yes, that's correct. What were some of the clues that helped you guys decide that this was an oligodendroglioma? Calcification, yes. Sheets, cysts, areas of calcification, yes. Okay, good job. So an oligodendroglioma, again, this is another relatively low-grade tumor, grade 2, typically seen in adults in the 4th to 5th decade, and it's slow growing. And it has a slight male predominance. So what's really unique about this tumor is the fried egg appearance. So it's a round cell, you'll see the nucleus, and around the nucleus, it'll have this kind of halo. It also has delicate branching capillaries. So these are capillaries between the cells, and they're labeled as chicken wire because of the shape. And also the presence of calcification, as you guys correctly mentioned. Typically seen in the cerebral hemispheres, most commonly in the frontal lobe and the temporal lobe. And what's very important for you guys to know is the molecular mutations. So 1p, the most common ones are 1p, 19q co-deletion, and IDH1, IDH2 mutations. What's important about this 1p, 19q is that if the patient has this, that means that this is a tumor that will respond well to treatment as compared to a tumor that doesn't have it. So here's what it looks like on histopathology. Can you guys appreciate the fried egg appearance? The nucleus looks like the yolk of the egg, and then the rest of the cell looks like the egg whites. The cells are also pretty uniform, so they all kind of look the same. You have the presence of calcifications, and between the cells, you have these delicate branching capillaries. And this is termed as chicken wire because it resembles chicken wire, apparently. And here's what it looks like on like the actual brain. It's a well-circumscribed, soft grayish tumor that has, again, calcifications, cysts, and focal hemorrhages. Okay, an 11-year-old girl has had increasing headaches upon awakening for the past month. On examination, papilledema is present bilaterally. An MRI of her brain reveals a 3-centimeter solid circumscribed mass within the 4th ventricle. There's third and lateral cerebral ventricular dilation. The mass is excised and microscopically shows perivascular pseudo-rosettes with round regular tumors arranged around vessels. Which of the following neoplasms is she most likely to have? Okay, yes, it's B, ependymoma. So why do you guys say B? Within the 4th ventricle, yes. 11-year-old, yes. Ventricle, yes. And perivascular pseudo-rosettes, yes. Okay, so what would it look like on histopathology? This is A, B, C, and D. Okay, I'm getting a couple of C's. I'm getting a B. 2, B. Okay. So this was a trick question. A, B, and C are all ependymomas. The only one that wasn't was D, which was a glioblastoma. Okay, which of the following immunohistochemical stains are positive in this tumor? Okay, I'm getting an A and a B. And a D. Okay, the correct answer is A, GFAP S100, Vimentin, and EMA. For this one, honestly, you just have to memorize the stains. Just know that ependymoma has all the, like every single stain, these four. It has so many stains compared to the other tumors, which just have 1 and 2. Just to help you rule out the others. So CD20, this is a B-cell marker. You would see it in B-cell lymphoma. Chromogranin, I'm not sure you guys took this one, but yeah, it's not for this tumor. 1p19q, we said this was for oligodendroglioma, and then NSE, I don't think you guys took this one either, so you can easily rule out the others. Okay, so ependymoma, usually grade 2, that's a classic ependymoma. However, it can be grade 3, which is anaplastic ependymoma, usually seen in children and young adults. And in the histology, what's very important is perivascular pseudorosettes. So perivascular, that means it's around the blood vessels, and pseudorosettes because they make kind of like a rose shape or a flower shape. Also true rosettes. So true rosettes are tumor cells that surround an empty lumen. You also have round nuclei with a fibrillary background. And grossly, you would see solid or papillary masses that extend from the ventricular floor. And that's because ependymomas, they arise from the ependymal cells, and these are the cells that actually align the ventricular system and they produce CSF. So the location depends on whether it's in a child or in an adult. In children, it's most likely seen in the posterior fossa or the fourth ventricle, which leads to hydrocephalus. And then in adults, you would typically see it in the spinal cord. As for the stains, 4 different stains: GFAP, S100, Vimentin, EMA. This is the only tumor that we've taken that has like 4 different stains. And for the molecular, it has NF2 mutations, and these are specifically associated with the spinal ependymomas, which again are more commonly seen in adults. The prognosis depends on the age. So if it's in a younger person, it has a better prognosis. On the excision, if it was completely excised versus if there was any part of the tumor that was left over. On the histology, so if it's better differentiated, CSF dissemination, if it's spread through the CSF to other parts of the body, and also the location. So supratentorial and spinal, completely resected supratentorial and spinal ependymomas carry a better prognosis as compared to completely resected ones in the posterior fossa. So here, can you guys see the rosette and the pseudo-rosette shape? Basically, it's a ring of tumor cells that surrounds a lumen in the center. So when it comes to perivascular pseudo-rosettes, it would surround a blood vessel. And when it comes to true rosettes, it would surround an empty lumen. Also, the cells, they're uniform, so they all kind of have the same shape with round to oval nuclei and abundant granular chromatin. So here are the other pictures. Again, you can appreciate the shape of the rosette, the pseudo-rosette, or the perivascular rosette. So just the circle of cells surrounding a lumen, here and here. So the ependymoma actually has 2 different subtypes. Oops. There is the myxopapillary and there's the anaplastic. So myxopapillary is typically seen in a myxoid background with papillary elements. A myxoid background just means one that has a lot of mucin. It's typically located in the phylum terminal of the spinal cord, and it has cuboid cells with clear cytoplasm around papillary cords. This is a relatively low-grade subtype, grade 2. This is in comparison to the anaplastic one. So the anaplastic is a little bit more concerning because it has more cell density, high mitotic rates, necrosis, and less ependymal differentiation. So there aren't any pictures that you guys have to know for these 2. Just make sure you know the different keywords for the different types of subtypes. Is that clear? Everything about ependymomas?
Yeah.
Okay. Which of the following statements about gangliogliomas is correct? They are high-grade tumors commonly seen in the posterior fossa. They are composed of both glial and neuronal components. They typically present with weakness and ataxia. They are most commonly found in the occipital lobe, or they are usually diagnosed in elderly patients. Okay, so I got 1B. Does anyone else want to answer? Okay, another B. Yes, that's correct. They are composed of both glial and neuronal components. So the other statements are incorrect because gangliogliomas are typically low-grade tumors. They're usually found in the temporal lobe, actually, so they wouldn't present with weakness and ataxia, rather they would present with seizures, and they're usually diagnosed in young children. So this is just a quick summary of the neuronal tumors that you guys took. The first one is ganglioglioma. It's just a mixture of mature neuronal and glial cells, and it has some cystic components and superficial lesions typically found in the temporal lobe. It has a mutation in BRAF. So BRAF, if you guys didn't know, this is just for your information, it's a component of the MAPK pathway. And what was another tumor that we took that had dysfunction in that pathway, if you guys remember?
Was it pilocytic astrocytoma?
Yes, exactly, pilocytic astrocytoma. Then you have central neurocytoma. So this is just a grade 2 tumor, evenly spaced around a uniform nuclei, and it's usually found within or adjacent to the ventricular system. And then lastly, you have the dysembryoplastic neuroepithelial tumor, low grade 1, found in the superficial temporal lobe. Okay. A 5-year-old boy presents with progressive headaches, nausea, and ataxia. MRI reveals a midline cerebellar mass with hydrocephalus. A biopsy shows small, round, hyperchromatic cells arranged in Homer-right rosettes with high mitotic activity. Immunohistochemical staining is performed to confirm the diagnosis. Which of the following stains is most likely to be positive in this tumor? Okay, I got 1A, 1B, okay, the correct answer is B, synaptophysin. First of all, what kind of tumor is this? Medulloblastoma. Yes, correct. So where would we see GFAP? Astrocytes, exactly. So you would see it in astrocytomas. CD20s are B-cell markers, so you'd see them in B-cell lymphomas. EMA, we just took it for ependymomas, and Desmond was not included. I don't think you guys took it. So you're correct. This is a medulloblastoma. A 2-year-old boy presents with irritability, vomiting, and an increasing head circumference. MRI reveals a large, heterogeneous, enhancing mass in the posterior fossa with necrosis and hemorrhage, causing obstructive hydrocephalus. A biopsy shows highly pleomorphic cells with rhabdoid features, prominent nuclei, and eosinophilic cytoplasm. Immunohistochemistry reveals loss of INI1 expression. Which of the following genetic alterations is most likely associated with this tumor? Okay, I got 1E, 1C, 2 C's. Okay. Yes, you guys are correct. The correct answer is alterations in chromosome 22. Do you guys know what type of tumor this is? Yes, rhabdoid tumor is correct. So let's just go over the other ones. A is seen in which type of tumor? Oligodendrogliomas. Yes, correct. B? Okay. Yes, B is seen in medulloblastomas. D is seen in astrocytomas. We took it. And then E is also seen in certain types of medulloblastomas, but you guys did not take that one. So let's talk about embryonal neoplasms. These are, or they originate from neuroectodermal, or they have neuroectodermal origins. And basically, these are cells that you would see in a developing CNS. So with people that have, fully developed and mature brains, you wouldn't really see these types of cells. These are small hyperchromatic cells. They're usually not differentiated or immature, or they are in the beginning stages of differentiation. So examples of these are medulloblastoma, that's the most common one, neuroblastoma, and atypical teratoid rhabdoid tumor. So medulloblastoma, this is a very, very highly malignant tumor. And in fact, it's the most common malignant brain tumor in children. The peak incidence of it is in childhood and adolescence. What's really unique about this one for histopathology is the presence of home-or-right rosettes. So home-or-right rosettes are tumor cells that surround an eosinophilic neuropil core. So all the rosettes we took so far, it's tumor cells that surround a lumen. Sometimes it's empty, sometimes it has a blood vessel. Here, for home-or-right, they surround a neuropil core. And do you guys know what neuropil is? Just a bunch of axons. Yeah, basically that's what it is. It's just a collection of axons. Basically, it's like the CNS version of connective tissue. So that's the most important feature. Some of the other features that it can have are small round blue cells with high nuclear to cytoplasmic ratio and highly frequent mitosis. It's located in the cerebellum exclusively, usually in the midline, and it grows very rapidly and compresses the fourth ventricle, causing hydrocephalus. That's why patients will present with things like headaches. As for the stains, it's positive in synaptophysin, synaptophysin positive, neurofilament positive, and vimentin positive. The prognosis of this is poor, especially if it's untreated. However, it does have a better prognosis if it's treated with surgery, radiation, or chemotherapy, and it can disseminate through the CSF. So here's what it looks like on histopathology. You can see the home or right rosettes, which are the rings or the circles of tumor cells that surround the area of neuropil. There's also mitotic activity, which you'd be able to see some nuclei that are separating, like here. And the cells are small and hyperchromatic, so they have like a darker color. And here's what it looks like on gross appearance. So notice how it's in the cerebellum. Okay, and for the underlying molecular mutations in medulloblastoma, so these are the ones that were mentioned in your lecture. I believe this one is the most important, WNT activated, because this indicates a good prognosis. And then some of the other ones are the sonic hedgehog gene activated TP53 mutation and the non-WNT, non-SHH. So for this one, it could be either MYC amplification or MYCN amplification. However, I don't think you need to know the details of this. Just know that they exist. Okay, so now we have an atypical teratoid or rhabdoid tumor. So again, this is a very highly malignant and aggressive tumor, grade 4, seen in patients before the age of 5. For the histology, you have divergent differentiation. So earlier we mentioned that these types of tumors, the cells are very immature, or when they are differentiated, they're differentiated at the very beginning stages of differentiation. So with this type of tumor, it's kind of a mess. You have some differentiation into epithelial cells, you have some differentiation into mesenchymal cells, some into neuronal cells, some with glial cells, and it often includes rhabdoid cells. So rhabdoid cells, this is an atypical type of cell. You don't have to know what it looks like, just know that it's present in this type of tumor. Usually found in the posterior fossa and the supratentorial compartments. And as for the stain, so normally, all nuclei that are normal, they stain with something called INI1 protein. For this tumor, that's absent. They don't have that. And then for the molecular mutation, underlying genetic mutation, is that there would be alterations in chromosome number 22. And unfortunately, it has a very poor prognosis. Okay, a 39-year-old HIV positive man has received no antiretroviral therapy. He has had left-sided weakness for the past month and experienced a generalized seizure a day ago. On physical examination, he is afebrile. CT scan of the head shows no intracranial hemorrhage, but there is a midline shift. MRI of the brain shows a 4-centimeter mass in the region of the putamen near the right internal capsule, a 3-centimeter mass in the right centrum semi-ovale, and a white centimeter mass near the splenium of the corpus callosum. These masses are circumscribed and solid. CSF from a lumbar puncture shows an elevated protein concentration and a normal glucose level. Cytologic examination shows large cells with large nuclei and scant cytoplasm that mark with CD19, but not with GFAP or cytokeratin. What is the most likely diagnosis? D, yes, correct. Large B-cell lymphoma. So what helped you guys narrow down your diagnosis? HIV, yes. Yeah, that's the most important thing. And CD19. So this type of tumor is typically seen in immunocompromised patients. So whether they have HIV, AIDS, or they're taking immunosuppressants, for example, after a transplant. So primary CNS lymphomas, these are high-grade aggressive lymphomas that can be seen in any age group, but more common in immunosuppressed individuals. As for the histology, it's very simple. You would just see diffuse large B cells. The location has multiple tumor nodules within the brain parenchyma, commonly periventricular. Now, what's unique about this is that usually primary brain tumors are solitary. So it would just be a solitary mass, solitary lesion, but this one would have multiple. As for the stains, again, it would be positive for CD20 and CD19. These are just general B cell markers, and it has a poor prognosis. It responds very poorly to chemotherapy, especially when you compare it to peripheral lymphomas, so outside the CNS. And just a quick review of germ cell tumors. So these are tumors that are seen in young ages. And basically they're immature germ cells. So germ cells, these are the cells that you would see in the gonads, for example, the testes and the ovaries. You could see them extragonadal, and they would always be in the midline structure. So in the context of the CNS, that would be in the pineal and the suprasellar regions. Poor prognosis, it doesn't respond well to chemotherapy. And one thing, or just one extra fact that you should know about it, is that germinoma, this is the most common type, and on histology, it resembles a testicular seminoma. Okay. A 45-year-old woman has had unilateral headaches on the right for the past 5 months. Physical examination yields no remarkable findings. The representative gross appearance of the lesion seen on CT scan of the head is shown in the figure. The mass is surgically removed, and microscopic examination shows elongated cells with pale oblong nuclei and pink cytoplasm with occasional seminal bodies. Cytogenetic analysis shows 22 chromosome. What is the most likely diagnosis? C. Yes, that's correct. This is a meningioma. So what helped you guys decide that this was a meningioma? Epidemiology, seminal bodies, yes, correct. And also just the picture for meningiomas, it's very distinctive. So it's just a mass that's coming right out of the meninges. Yani there's nothing else that you can confuse it for. So I want you guys, whenever you see this picture, to know automatically that this is a meningioma. So for the grading of the meningioma, most of them are grade 1, which is benign, but then you could also have grade 2, which is atypical, and grade 3, which is anaplastic. So this is more common in adults, in females, and this is usually found in older patients. Now, these tumors are very, very slow growing, and they're actually usually found incidentally. So, you know, they go in for some other thing and they get a CT scan done, and then it's found that they have a meningioma. So as for the histology, there are 4 different patterns, and we will look at them. As for the location, so this is an extraaxial type of tumor. That means it's not coming from within the brain parenchyma, but rather from the outside, specifically the meninges. You would usually see it in the cerebral convexity or in the fossa cerebri and the skull base. As for the molecular mutations, so there's loss of chromosome 22. This is also known as neurofibromatosis type 2, or NF2. Now, there is another mutation, which is the TERT promoter mutation or homozygous deletion of CDKN2A/B. And the significance of this mutation is that it usually represents a more aggressive tumor. So if the tumor has this mutation, then it's automatically grade 3. The prognosis is again determined by the size and the location, whether it's easy for the surgeon to get it out without damaging any nearby structures, as well as the histological grade. So for just some extra facts, meningioma, generally speaking, it's a well-defined tumor, and it may compress the brain, but it does not invade it. And because of that, it's usually asymptomatic unless it's actually compressing brain structures. The atypical meningioma, to diagnose this, it's very important that, first of all, you see 4 or more mitoses per 10 high-power fields. And what this means, essentially, is that you look under a high-power, I was going to say magnifying glass, microscope, and then you do this 10 times, each with different sections, and then in each section, you want to count 4 or more mitoses. Once you do that, then you want to look for 3 of these other features. The first one is high cellularity, small cells, high NC ratio, which means the nucleus is taking up a huge chunk of the cell, more than what it should be, patternless growth, and necrosis. Also, if you see clear cells, then this means that it's a bad prognosis, or they'll have a bad prognosis. And then lastly, you have the anaplastic one, which is very, very aggressive, and it mimics another tumor, sarcoma, and it has a very bad prognosis. So meningiomas are diagnosed by CT scan. Again, we mentioned earlier that it's usually found incidentally, so they go in for a CT for something else, and then they would see it. Complete excision may cure most meningiomas, and the extent of precision is the most important in determining recurrence. So if you make sure that you take clear cell margins, you remove as much as possible, then that would be the most important thing in determining whether it will come back or not. And after it's resected, you would do radiotherapy to get rid of any remaining parts of the meningioma. So these are the 4 patterns. Can you guys tell me what they are, starting with this one? Transitional. Okay, yes, correct. This is transitional. What about this one? Samoma. Yes, correct. This one?
Fibroblastic?
Yes. And lastly, this one? Syncytial. Good job. Okay, so I know that these can get a little bit confusing, especially these 3 or these 2. So just to help you guys remember them. So Samoma, these are very distinctive because of the calcifications, like you won't confuse it with anything else. Fibroblastic, they're kind of just very straight lines compared to transitional and syncytial, where you can see these kind of whirling patterns. For syncytial, so the thing about syncytial is that it's describing syncytium, which means that the cells, it's hard to tell where one cell ends and the next one begins. You don't really see any cell borders. Additionally, the cytoplasm of the cell is very eosinophilic, so it appears kind of very pink, and the nuclei are also darker. Transitional is somewhere in between fibroblastic and syncytial, so it would have some features of both. From syncytial, it kind of resembles the whirling or the swirling pattern. From fibroblastic, it has a similar nucleus, which is the spindle-shaped nucleus. Is this clear? Okay. Okay, so this whole entire time we were talking about primary brain tumors, which are tumors that originate in the brain, but actually the most common type of tumors are metastatic tumors, which means that the most common type of intracranial tumors are metastatic tumors, which means they come from somewhere else in the body. So the primary sources for these are the lung, especially if they're males, they're smokers, they have a lung carcinoma, and for females, it would come from a breast carcinoma. So radiological features is that they typically present as multiple, so this is important, sharply demarcated lesions located at the gray-white junction. And they often show ring enhancement with surrounding vasogenic edema. So if you see a solitary lesion, that's likely to be a primary brain tumor, with the exception of, do you guys remember which one would have multiple lesions or nodules? Yes, B-cell lymphoma. Okay.
Okay, well, guys, I'm back. Okay. So inshallah, CNS tumors was a huge chunk, but inshallah, we're almost done. So the next question is, a 55-year-old man had increasing difficulty with initiation of voluntary movement and increasing inability to perform activities of daily living for 1 year. He became bedridden and died of pulmonary thromboembolism. The left side of the figure shows the gross appearance of the midbrain of this patient, and on the right is a normal midbrain. What additional clinical feature is most closely associated with this lesion? So this is the normal, this is the abnormal. Okay, so I see people saying A. So what does the patient have? And what do you see on the image? Okay, Parkinson's. And what do you see on the image? What's abnormal in here? Yep, exactly. So it should be pigmented. This is the substantia nigra, and here, as you can see, it's not as pigmented. So yes, it is pill rolling tremor, which is a sign or a symptom of Parkinson's disease. Symmetric weakness in the extremities you'd see with some sort of motor neuron disease. Choreiform movements, where do you usually see this? Huntington. Difficulty with short-term memory would be more of Alzheimer's kind of thing. Paraplegia would be some sort of nerve injury. So yeah, this is Parkinson's. So what is Parkinson's? Parkinson's is like someone said, it is the degeneration of dopaminergic neurons in the substantia nigra. The neurons, if you look at them under the microscope, you're going to find intracytoplasmic inclusions. What are they called and what are they made of? If you know. The inclusions in part, okay, it's made of alpha-synuclein. That's what's the inclusion itself called. Lewy body. Yes, okay. So it is Lewy bodies, and they are made of alpha-synuclein. And the symptoms are tremors, which are usually pill rolling tremors, and they're usually asymmetric. Rigidity, which is normally if you just like passively move someone's hands, it's just gonna go up and down and easily. But with rigidity, you're going to find resistance all the way. So they can have this lead pipe rigidity or like cogwheel rigidity. A is akinesia, so they have abnormal movements. Bradykinesia, they have the masked faces. Their voice, it's monotonous. They can't have expressions. And then P is for postural instability. So if you pull them, they're not able to balance basically. So they might end up falling. So they have a lot of falls. And as you can see, they also have stooped posture. And they can have also symptoms that are not related to the motor system, like depression. They can have the sense of smell, anosmia, and autonomic symptoms like they can have lightheadedness and dizziness and so on. Orthostatic hypotension, basically. So yeah. Okay. So this is a Lewy body. You can see them. They're inside the pigmented cells in the substantia nigra, which are the dopaminergic cells. Okay. Okay, next question. A 42-year-old man has had increasing difficulty performing activities of daily living for the past year because of worsening choreiform movements. His family reports that his behavior has changed. Although his memory remains intact, his older brother is similarly affected. On physical examination, he is afebrile, normotensive, cranial nerves are intact, he has no motor weakness, no sensory deficits. Which of the following mechanisms is most likely responsible for his disease? So I see C, Huntington. Yes. So what here tells us it's Huntington? Number one, the age is kind of young, choreiform movements. And he has change in behavior, but the cognition is fine. And there's no motor nor sensory issues. So it is Huntington. What would A be? Loss of pigmented neurons in the substantia nigra. We just mentioned it. Parkinson's. What about B? Cognophilic angiopathy of the cerebral cortex. Congophilic. If we break it down, congophilic, that means it attracts the Congo red stain. No, so what substance you look at with the Congo red stain? And then it turns apple green by birefringence. Amyloid, right? So which disease has amyloid issues or amyloid accumulation? Amyloid plaque, yes, Alzheimer's. So this is just basically telling you that this is Alzheimer's. C, atrophy and gliosis of the caudate nuclei, which is Huntington. Loss of motor neurons in the cerebral cortex and brainstem. This would be more of ALS, perfect. And multiple lacunar infarcts within the basal ganglia, that's more of stroke kind of thing. Yeah, okay. So as you can see, Huntington is a degeneration of the GABAergic neurons. In Parkinson's, it was dopamine. In Huntington, it's GABA. And it's in the striatum, which is the caudate and the putamen. So that's why you're going to have atrophy of the caudate and the putamen. And generally, there's going to be a ventricular enlargement when you look at it on imaging or under gross anatomy. So mutation is in which gene, and what's the sequence that has the trinucleotide repeat expansion? Chromosome 4, okay, but gene, CAG, yes, Huntington gene, exactly, perfect. So that is correct. So Huntington gene, and it's the CAG trinucleotide repeats. You're going to find internuclear inclusions, which are from the Huntington genes themselves. And something special about trinucleotide repeats in general, they have something called anticipation. Anticipation means that newer generations are going to have larger and larger expansions of trinucleotide repeats, which means they're going to get earlier symptoms, and they might also get it worse than their previous. So for example, let's say the father gets the disease at 50 years old, then his son might get it at 46, something like that. And the symptoms, they have chorea, they're going to have behavioral changes like irritability and so on, and they might also have psychiatric symptoms like depression and other stuff. And they have a very high rate of suicide. It's a very disabling disease. Okay, next question. A 68-year-old woman with a 7-year history of progressive dementia dies of bronchopneumonia. At autopsy, there is cerebral atrophy in a predominantly frontal and parietal lobe distribution. Microscopic examination of the brain shows numerous neurotic plaques in the hippocampus, amygdala, and neocortex. Congo red staining shows amyloid in the media of the small peripheral cerebral arteries. Which of the following conditions is likely to be the most important factor in the development of her disease? Okay, so I see 1C. Anyone? Okay, C. Yes, you are correct. Yeah. Okay, so yes, it is C. The ApoE4 gene is associated with higher Alzheimer's disease incidence. The HLA-DR3, DR4 is not related. This is usually common autoimmune diseases. Expansion of CAG repeats, we just mentioned, is Huntington. Inheritance of a mutant prion gene, would you know? I'm not sure if you took that. The prion disease. Yes, Creutzfeldt-Jakob disease. Perfect. And that will usually represent with 7-year history. It's going to be something very short, very acute term. So like 4 months, 6 months, they're going to have their dementia, the seizures, myoclonus, and so on. Okay, and deficiency of thiamine, what would that give you? Wernicke, yes, Wernicke-Korsakoff. Encephalopathy, Wernicke's encephalopathy. And usually that's with chronic alcoholism or maybe someone with anorexia. Okay, so Alzheimer's disease is the most common cause of dementia. It's a mutation in which gene and on which chromosome? Yes, APP gene on chromosome 21. And why is that important? Other than the ApoE4, which other community of people will also have? Exactly. So Down syndrome, they're going to have higher chances of Alzheimer's because they have an extra copy of the chromosome 21. Okay. So I'll just show it to you and then go back. Okay. So symptoms early on, they're going to have progressive short-term memory loss. And then eventually they're going to have executive dysfunction. They're not going to be able to do their activities of daily life. They're going to have like visuospatial disorientation. They're going to get lost, so on. As you can see on imaging, you're going to find atrophy, hippocampal atrophy, and also just in general diffuse cortical atrophy, maybe mainly the frontal and the parietal lobe. And you're going to find ventricular enlargement, and this is called hydrocephalus ex vacuum. So where you find enlarged ventricles with atrophy of the cortex. Okay, so here's just simple, quick pathophysiology. You have the APP, the protein. Normally, it gets broken down by alpha secretase in a certain position. The things that are broken down by alpha secretase and then gamma secretase, it's soluble, so nothing happens. What happens in Alzheimer's disease, instead of alpha secretase, beta secretase cuts it in a different place. And then gamma secretase comes and cuts it. So what's left here is going to be insoluble, and that's what accumulates. And that's what gives us the Alzheimer's disease, basically. So what are 2 findings under histopathology you can find in Alzheimer's disease? Mhm. Under the microscope, what can you see? Plaques and tangles. So the plaques are amyloid plaques, and the neurofibrillary tangles are made up of what? Tau. Perfect. So hyperphosphorylated tau. So Bismillah. So these are the amyloid plaques, and then you can see the fibrils in here, the tangles. Okay. Next question. A 55-year-old man dies of aspiration pneumonia after a 6-year illness, characterized by progressive symmetric muscular weakness. At autopsy, the brain and spinal cord appear normal on gross examination. Microscopic section shows gliosis in the motor cortex, pallor of the lateral corticospinal tract, and neuronal loss in the anterior horns of the spinal cord. What is the most likely underlying cause of death? So I see E, ALS. That is correct. So what do you see in this patient? We see a progressive disease. It's symmetric. The muscle weakness is symmetric. And we see pallor of the lateral corticospinal tracts from the name lateral sclerosis, so lateral tracts, but also neuronal loss in the anterior horns. So this says, it's upper motor neuron lesion and lower motor neuron lesion. Perfect. Becker muscular dystrophy, I think you took MSI, but basically it's Duchenne's friend, but less severe. Neurofibromatosis type 2, nothing gives that. Guillain-Barré syndrome is ascending muscle weakness, but also it's demyelination, no upper motor neuron sign, only lower motor neuron lesion. Creutzfeldt-Jakob, this is not yet, as we mentioned before, the prion disease. So ALS is a pure motor disease, and it can have a familial part, which is due to hexanucleotide repeat expansions. So there's death of lower motor neurons and upper motor neurons, as you guys mentioned. And so the symptoms will include lower motor neuron signs and upper motor neuron signs. So what are some lower motor neuron signs? Atrophy, fasciculations, flaccid paralysis. What about the reflexes? Yes, hypotonia and the reflexes is perfect. Okay, what about upper motor neuron signs? Babinski, perfect. Spastic, perfect. And hyperreflexive. Okay, so yes. Tamam. So you can find both of them. So for example, you can find tongue fasciculation and then you do Babinski and it's positive. You can find no reflexes in the upper limbs and then you'll find hyperreflexia in the lower limbs. Eventually, they're not going to be able to walk. They're not going to be able to talk. They're not going to be able to breathe. So it's a very devastating disease. Tamam. Oopsies. I'm so sorry. Okay, it's Safia's time.
Can you guys see my screen?
No.
You can't see it?
Yes, sorry. Yep.
Okay. A 32-year-old woman presents with blurred vision in her right eye and pain with eye movement for the past week. She reports that she had an episode of numbness and tingling in her left leg 6 months ago, which resolved spontaneously. Physical examination reveals a relative afferent pupillary defect in the right eye and decreased sensation in the left leg. MRI of the brain shows multiple hyper-intense white matter lesions on T2-weighted imaging, particularly in the periventricular region. CSF analysis reveals oligoclonal IgG bands. Which of the following is the most likely diagnosis? Okay, so everyone is saying B. What were the clues that helped you guys diagnose this patient? Oligoclonal IgG bands, correct. Periventricular lesions. What else? Epidemiology, yes. Middle-aged women, optic neuritis, all correct. Okay, so multiple sclerosis is an immune-mediated demyelinating disease of the CNS. So it's caused by T cells, and it's a type for hypersensitivity reaction, so T cell mediated, with macrophages phagocytosing myelin. So it affects the white matter, and it has a genetic predisposition with HLA-DR2. So these are the symptoms that the patient usually presents with. They would have cognitive changes, depression, dizziness and vertigo, blurred vision, and temporary blindness. This is important. Fatigue, diarrhea, constipation, urinary incontinence, and sexual problems, numbness, pain, stiffness, spasm, and difficulty walking with muscle weakness. So for the pathophysiology of multiple sclerosis, this is an autoimmune T cell mediated disease. So it starts with autoreactive T cells that somehow enter the blood-brain barrier. So the blood-brain barrier becomes a little bit loosened, so the T cells are able to enter. And here they interact with B lymphocytes, microglia, and macrophages. So when they activate the macrophages are going to phagocytose the myelin. When they activate the B lymphocytes are going to create autoantibodies against the myelin, which also helps with their phagocytosis, and it's going to interact with the microglia. The microglia are going to release inflammatory cytokines, which further loosens the blood-brain barrier and allows more autoreactive T cells to come in. Okay, so this is the same case. A brain biopsy of an active MS lesion would most likely show which of the following findings? Okay, I'm seeing B. And yes, that is the correct answer. So this is what it looks like on histopathology. You have the blood vessel in the middle, and it's surrounded by these lymphocytes. And there are also foamy macrophages in the periphery. And the reason why the macrophages are foamy is because they phagocytose the myelin sheath. And here is what the plaques look like. They're well demarcated gray gelatinous plaques. And the reason why they have this color is because of the demyelination. So to diagnose multiple sclerosis, it has to meet the McDonald criteria. So the McDonald criteria are, it has to have dissemination in time. So the plaques, there have to be new CNS lesions over time, and dissemination in space, so in different locations. The gold standard for diagnosing multiple sclerosis is MRI. So with the MRI, you would be able to see multiple periventricular white matter plaques, which we'll look at in a minute. And when you have active lesions, they will become enhanced when you give contract. And the lesions would specifically be located in the periventricular region. So this is the most common. And you can also see it in subcortical, infratentorial, and spinal cord regions. You could also do a CSF analysis. As you guys correctly mentioned, you would be able to see oligoclonal IgG bands. So this is what the MRI looks like. And these are the enhancing lesions where you would see the plaques of the MS. Okay, so for the classification of MS, you could have relapsing remitting or primary progressive or secondary progressive. So with relapsing remitting is that you would have different exacerbations over time. And between each of the exacerbations, the disability that you have will increase. So after your first exacerbation, you won't go back to your normal function. And then after your second, you'll be even worse off until eventually you become disabled. With primary progressive, it's just progressive from the start. So you don't really recover in between episodes, or there aren't really episodes for you to recover in between. And secondary progressive is between the two. So you would have relapsing remitting and then primary progressive and then progressive. Okay, a 20-year-old man presents to the emergency department with fever, severe headache, nausea, and neck stiffness for the past 12 hours. On examination, he is febrile and has photophobia and a positive Brudzinski sign. His family reports that he has been increasingly confused over the past few hours. Which of the following is the next best step in confirming the diagnosis of meningitis? Okay. So I'm seeing some A's, B's, and C's. The correct answer is B. So just focus on the question. It says to confirm the diagnosis of meningitis. The C makes the most sense. Obtain a CT scan of the head. Actually, it does make sense to perform a CT scan of the head. Why do you guys say so? Herniation, yes, exactly. So with meningitis, you have the risk of increased intracranial pressure. So before you perform the lumbar puncture, you want to make sure that it's safe to do so, because if you do it and the opening pressure is very high, there could be brain herniation. So I will fix this. Okay, so meningitis is an infection of the meninges. It can be either acute or chronic. So acute means that it develops within days to hours, and chronic means that it's over 4 weeks. And the longer that you have it, the more that it would indicate that it's related to immunosuppression or some sort of fungal infection. It could be bacterial. So what are some bacterial causative organisms that you guys know for meningitis? Strep pneumo, yes. Neisseria, yes. Agalactia, yes, that's very important, especially in young children, and Listeria. It could also be viral. So echoviruses, arboviruses. It could be fungal, like Aspergillus or Cryptococcus. It could be protozoa, like Naegleria fowleri, and this is important for people that live in hot climates and they go swimming. Or it could even be spirochetes, like Treponema pallidum. So when you have a patient with meningitis, it's very important to take a good history. You want to ask about risk factors and exposure. So what kind of causative agents would you think about if they tell you they've been exposed to sick animals? Listeria, yes, correct. Patients with similar disease and also sexual contact, because that could raise flags for HIV and make you think of fungal organisms. So as for the other risk factors, you can split them first into ones that are like by location, like respiratory infections, otitis media, and head trauma, because these would make you think that the infection spread from somewhere else in the body, versus splenectomy, diabetes, and cirrhosis. So these are like immunocompromised states where your body can't really fight off encapsulated organisms, which makes you prone to infection. So as for the pathogenesis of meningitis, the bacteria would enter from the mucosa. So the mucosa typically has IgA, which helps protect it, but some of these bacteria have proteases, so they can digest the IgA and make their way into the bloodstream. In the blood, or from the blood, they can enter the blood-brain barrier and accumulate here in the brain. And then to fight this off, there would be white blood cells that come from the blood and they enter the brain. Now, because of the accumulation of the bacteria and the white blood cells, there would be edema, which leads to increased intracranial pressure. And the mechanism of edema happens through 3 ways. The first one is the white blood cells that enter the brain will start to release cytokines, which makes the blood-brain barrier a little bit less loose and therefore more leaky. Because it's more leaky, proteins from the blood can enter the brain and stay here, therefore leading to edema. And also the presence of the bacteria and the white blood cell and all the proteins here will also lead to further edema. Does that make sense? Now, because of this edema, it could lead to increased intracranial pressure, which is why it's very important to do a CT scan before you do a lumbar puncture. So these are the 3 most important symptoms of meningitis, which are fever, headache, and stiff neck. And then some of the other ones could be photophobia, nausea, vomiting, confused, altered mental state, and they could even have seizures. So to diagnose meningitis, you would take a CSF sample, you would do a blood culture, CSF culture, and an analysis, and you would also just look at the CSF. So for bacterial meningitis specifically, I want you guys to focus on this. The appearance of it would be turbid or cloudy as compared to normal CSF, which should be clear. It would have an elevated opening pressure, and that's because of the edema leading to increased intracranial blood pressure. It would have a high number of white blood cell counts, and this would be specifically neutrophil predominant. It would have a high amount of proteins and low glucose because the bacteria would be using up the glucose. As for the prognosis of meningitis, it depends on a few different factors. One of them is age. So in younger patients, it would have a better prognosis. The presence of comorbidities. So if you don't have comorbidities, you would have a better prognosis. Seizure within 24 hours of admission or a decreased level of consciousness on admission, so an altered mental status. If there's a delay in the initiation of treatment, and then specific organisms like strep pneumo and Listeria monocytogenes, these carry a worse prognosis. And that's it for my parts.
Sorry. There we go. Okay, guys, can you see my screen? Okay. So this is the last lecture, which is just about CSF. I'll have you fill this out. So in bacterial meningitis, the appearance of the CSF, normally it's clear. What would it be in bacterial meningitis? Turbid and, sorry, turbid. And in TB meningitis? Okay, so in TB meningitis, yes, the fibrin. It's cobweb appearance or fibrin web, which is basically there's very high amounts of protein that it looks like a spider web. So what about viral meningitis? Clear, yes. So cell count in bacterial meningitis, is it normal or high? High. In TB meningitis, it's high. And in viral meningitis, is it normal or is it high? Yeah. It's also high. So what is the predominant white blood cell in bacterial meningitis? Polymorphic, okay. And in TB? Lymphocytes. And in viral? Lymphocytes, okay, perfect. طيب, in what about protein in bacterial meningitis? Is it normal or okay? High. And in TB? Also high, super high. And in viral meningitis? Yeah, so it's usually normal. It can be slightly elevated, but mostly normal. What about glucose? Is it normal? Okay, it's low. In TB? Also low. And in viral meningitis? Okay, it's normal or it can be slightly low. What about chloride? So chloride is normally higher in the CSF than in the blood. What would it be? Okay, low, yes. And in meningitis, TB is low. And in viral, same thing, normal or slightly low. Perfect. But these are clue words, and just tell me what you associate this. If you see xanthochromia in CSF. Subarachnoid hemorrhage. Oopsies. Okay. Oligoclonal bands. Multiple sclerosis. Albuminocytological dissociation. GBS. Perfect. Okay. So xanthochromia is just basically, xantho means yellow, so yellow, because the blood is going to break, the RBCs break down and give you bilirubin, which is yellow. Okay. All right. Okay, yeah. Oh, so we're done. Now this is the rapid fire questions. So I have questions, Safia has questions, and let's see how you do. Tamam. So I'm gonna share the screen, and when it's Safia's turn, she's gonna. Okay. So a 63-year-old man has been receiving hemodialysis for chronic renal failure and has noted increasing loss of sensation in his legs for the past 4 years. On physical examination, there is symmetrically decreased sensation over both lower extremities. He has no decrease in strength or abnormality of gait. What is the most likely to produce these findings? Okay, so wait. Okay, most of you are saying D, and someone is saying it's chronic, so it can't be A. Correct, Yani. It's D. Sorry, it's D. Guillain-Barré would usually, what will happen? You know, there's previous infection, either GI or upper respiratory tract, and then they will have, yes, ascending paralysis. And it's not 4 years, it's going to be within a short time. Okay, cerebral astrocytoma, that does not sound like it's a tumor. And usually, Safia said it would present with seizures. Infarction, that would be a stroke. Again, stroke would present with sudden loss of movement or sensation, something like that. And multiple sclerosis, it's gonna be, it comes and goes, and it's different symptoms, optic neuritis, and I don't know. So yeah, diabetes mellitus, which causes the axonal neuropathy, the distal axonal neuropathy. Okay, Safia.
Which of the following MRI findings would most strongly support the diagnosis of MS? A, enhancing ring-shaped lesions with a central necrotic core. B, single hyperintense lesion in the basal ganglia with no periventricular involvement. C, Dawson's fingers, which are T2 hyperintense lesions radiating outward from the corpus callosum. D, a single enhancing demyelinating lesion without additional white matter involvement. Or B, bilateral symmetric hyperintensities in the temporal lobes. So everyone is saying C. That's correct.
Or this. So, okay.
Okay, a 32-year-old man with a history of sinusitis presents with fever, severe headache, photophobia, and altered mental status for the past 24 hours. Examination reveals nuchal rigidity and a positive Koenig sign. A lumbar puncture is performed, revealing CSF opening pressure of 290 millimeters of water. This is elevated. Cloudy CSF, white blood cell count of 3,200, 90% neutrophils. This is also elevated. Protein 280, this is elevated. Glucose 20, this is less. Which of the following best describes the most likely route of bacterial invasion in this patient? A, direct invasion from the paranasal sinuses. B, hematogenous spread via the choroid plexus. C, retrograde transport along the peripheral nerves. D, direct inoculation from trauma or surgery. Or E, lymphatic spread from cervical nodes. Yes, the answer is A, direct extension from the paranasal sinuses. So we mentioned earlier that meningitis can happen directly from, if the patient, for example, has a respiratory infection or otitis media, the infection would simply spread into the brain.
So I think this is my question. A 36-year-old woman is involved in a motor vehicle accident. She is not wearing a safety belt and is ejected from the vehicle. When paramedics arrive, her vital signs are stable with pulses. It's 80, respiration 17, blood pressure is normal. On examination in the emergency department, she has multiple contusions and abrasions over the skin of her head, torso, and extremities. There is no papilledema. There is no decerebrate posturing, and she has no spontaneous movements. She is not conscious. CT scan of the head shows no intracranial hemorrhage or edema and no skull fractures. She remains in a persistent vegetative state. What lesion is most likely to be present in this patient? Okay. Anyone else would like to also answer? Phi C and Phi D. Okay, so the answer is actually C. The answer is actually C, diffuse axonal injury. So let's look at this. She was involved in a motor vehicle accident. What is motor vehicle accident? Acceleration, deceleration. What does acceleration, deceleration cause? Diffuse axonal injury. So that's number one. Number two, she has, there's no papilledema, so there's no sort of increased intracranial pressure. No decerebrate posturing, which is, if you see in the Glasgow Coma score, they have the extension. So that means that the brainstem is intact. Otherwise, the CT scan of the head shows nothing. So acute hydrocephalus would be wrong because CT is showing nothing. Cerebellar tonsillar herniation is wrong. CT scan shows nothing. And also there is no increase in intracranial pressure. Hypoxic neuronal damage, and it doesn't really match what the picture is, especially with the motor vehicle accident, diffuse axonal injury. Cortical contusion, CT shows nothing. Myelinolysis, CT shows nothing. There's no like demyelination in the brain. So the answer would be C in this case. Okay, the next question. An 86-year-old man has become progressively unable to live independently for the past 10 years. He now requires assistance with bathing, dressing, toileting, feeding, and transfers. On physical examination, he has no motor or sensory deficits. He cannot give the current date or state where he is. 6 months later, he suddenly becomes comatose and dies. At autopsy, there is a large superficial left parietal lobe hemorrhage. Histologic examination of the brain shows numerous neocortical neuritic plaques and neurofibrillary tangles. The peripheral cerebral arteries and the core of each plaque stain positively with Congo red. That means it's amyloid. Which of the following mechanisms is most likely responsible? So I see A, what does this patient have? Alzheimer's. Yes. So it is A. What is B conformational change in the prime protein? C, yes, Creutzfeldt-Jakob, which will not present like this. Okay. Mutations in the tau gene. Why is C wrong? Yeah, there is hyperphosphorylation of the tau gene. Okay, yes, exactly. So the tau gene is not mutated. The gene that's mutated is the amyloid thing. Okay, so mutations in the frataxin gene, what is that? Yep, Friedreich's ataxia, which is the GAA. The dopamine deficiency, Parkinson's. Expansion of blood polyglutamine repeats, Huntington. Perfect. So CAG stands for glutamine. So it's gonna have basically this is just telling you that there is expansion of the CAG gene, which is glutamine. Okay. So GAA is frataxin, CAG is Huntington. Yep. A 55-year-old man who had been healthy all of his life now has progressive symmetric muscular weakness. 2 years ago, he noted weakness in the area of the head and neck, which caused difficulty with speech, eye movements, and swallowing. In the past year, the weakness in the upper and lower extremities has increased, and he can no longer stand, walk, or feed himself. His mental functions remain intact. What is the most likely diagnosis? So 1A, anyone has any other answer? A. Okay, yeah. So it is A. So you can see he has brain stem involvement, and then he has the other limb involvements, and also it's progressive. Like it started 2 years ago. It's not Huntington. They're gonna have choreiform movements. Multiple sclerosis, again, it's not multiple sclerosis, more relapsing, remitting, and it's gonna have sensory and motor. Guillain-Barré infection, and then ascending. This started at the head and neck. And then Parkinson's disease is also not going to present like this. It's going to present with the tremor symptoms, the pill rolling tremor, the rigidity, and then the bradykinesia and postural instability. Okay, Safia.
Okay. Juvenile pilocytic astrocytoma is the most likely diagnosis for which of the following clinical situations? A, a poorly defined cystic calcified tumor in the hypothalamus of an adult. B, a well-circumscribed cystic tumor in the cerebellum of a child. C, a well-circumscribed non-cystic tumor attached to the dura of an adult. D, an infiltrative non-cystic tumor in the cerebellum of a child. Or E, an infiltrative necrotic tumor that crosses the midline in an adult. B, yes. Okay, B is correct. So do you guys know what the other tumors are? A, which tumor has calcifications? Oligodendroglioma, yes, correct. A well-circumscribed non-cystic tumor attached to the dura of an adult. So dura is a meningioma, yes. D, an infiltrative non-cystic tumor in the cerebellum of a child. Medulloblastoma, yes, correct. And E, an infiltrative necrotic tumor that crosses the midline in an adult. Yes, glioblastoma multiforme, the butterfly tumor. Okay, a 45-year-old man presents with sudden onset fever, severe headache, photophobia, and altered mental status. Neurological examination reveals nuclear rigidity and a positive Brudzinski sign. A lumbar puncture and CSF analysis are performed. Which of the following is the most characteristic feature of bacterial meningitis on CSF analysis? B, yes, decreased glucose, elevated protein, and neutrophilic pleocytosis. So decreased glucose because the bacteria are using up the glucose, elevated protein because they actually have protein, and neutrophilic pleocytosis, so they have elevated white blood cells, specifically neutrophils. Follow-up question. What would the opening pressure be? Would it be elevated, normal, decreased, high? Yes, correct. Because of edema, yes.
Okay. So here I just have some pictures of CSF. So what would this be? It's clear. Is this normal CSF or? Yeah, so this is normal CSF. It can be viral. What about this? There's a lot of blood in all tubes. Subarachnoid hemorrhage. Okay, what about this? What do you see? Xanthochromia, but it's yellow in color. So that would also be subarachnoid hemorrhage. طيب, what about this? Traumatic tap, which means basically there was an injury, so there's blood in the first one, and then it gets diluted, and then it gets more diluted. So that's not subarachnoid hemorrhage. That for subarachnoid hemorrhage, it has to be all 3 tubes or 4 tubes. Okay, a 72-year-old man with diabetes has had a stepwise cognitive decline for the past 5 years. There's an acute event such as loss of consciousness or confusion, followed by worsening ability to perform activities of daily living. On physical examination, he has mild right hemiparesis, ataxia, and dysarthria. Which of the following pathologic findings is most likely to be present and numerous in this man? So he has some sort of dementia, صح? Okay. Okay. When, like, with the answer, tell me, what does he have? Like, why do you think it's the answer? Okay. So, okay. So this is kind of a trick question, to be honest. So what happens in Alzheimer's? In Alzheimer's, they have firstly short-term memory loss, and then they're going to eventually not going to be able to do their activities of daily living and so on. And it's usually progressive. Stepwise means it's right. It's not progressive in a way. Like, it's better, and then it gets suddenly worse and gets suddenly worse. Number one. Number two, there's an acute event, and then they're doing worse after the acute event. And then they have hemiparesis, ataxia, dysarthria. Those are not really symptoms of Alzheimer's, right? Alzheimer's doesn't really have motor or sensory deficits. It's just the brain, the cortex, يعني cognitive function. So, and also the patient has diabetes, which is very important risk factor for maybe mild strokes. So this patient actually has vascular dementia. So if he has vascular dementia, what would be the correct answer? They have an acute event, which is a stroke. And then they have hemiparesis, ataxia, dysarthria, which are signs of stroke. Yeah, so Lacunes is just like the lacunar infarcts. Now, it is A. It is A. So that's like, sorry. So that's what you're gonna find in like vascular dementia. You're going to find areas of infarct in the brain. And with each infarct, they're going to get more dementia. So Lewy bodies will be in either Parkinson's or dementia with Lewy bodies. Neuritic plaques and neurofibrillary tangles are both in Alzheimer's. So that's why it really can't be Alzheimer's, because both answers are here. So which one would you choose, Yani, unless you're planning to appeal the question? Pick bodies is the frontotemporal dementia, which presents with the behavioral changes first, not memory. And then plaques of demyelination would be like multiple sclerosis, which really these are not symptoms of multiple sclerosis. So yeah, it's a bit of a trick question. This was vascular dementia and not Alzheimer's. Okay, Safia.
A 5-year-old boy presents with projectile vomiting and progressive ataxia. Workup finds obstructive hydrocephalus due to an infiltrative tumor located in the posterior fossa and originating from the midline of the cerebellum. What is the most likely diagnosis for a tumor located in this location in this child? A. Glioblastoma multiforme. B. Dysembryoplastic neuroepithelial tumor. C. Primary CNS lymphoma. D. Primary germ cell tumor. Or E. Primitive neuroendocrine tumor. Okay, I'm seeing B. Can you tell me why you guys are saying B? Ependymo. Okay, I see. So dysembryoplastic neuroepithelial tumors, if I remember correctly, they're located in the temporal lobe. So this is another type of tumor. Okay, if you guys didn't have these options, what would be your guess? Midline of the cerebellum, that's the key word here. Just say anything. Okay. Medulloblastoma. That's exactly right. So a medulloblastoma is what type of tumor? Yes, it's E, primitive neuroendocrine tumor. So primary germ cell tumors, those are the germinomas, the ones that resemble seminomas. Primitive neuroendocrine tumors, so we took two examples of that. We took the medulloblastoma and we took the rhabdoid tumor. Dysembryoplastic neuroepithelial tumors are located in the temporal lobe. Primary CNS lymphomas, those are usually seen in patients that are immunocompromised, and glioblastoma multiforme, seen in older patients, doesn't really present with ataxia. And this is a 5-year-old boy. Does that make sense? Okay. A 55-year-old woman presents with the onset of seizure activity. CT scans and skull x-rays demonstrate a mass in the right cerebral hemisphere that is markedly calcific. The mass is removed and histologic sections reveal sheets of cells with clear halos, the fried egg appearance, and scattered calcification. The presence of which one of the listed abnormalities within this type of tumor is associated with a better response to chemotherapy? D? Okay, yes, D is correct. Do you guys remember what these other mutations are for? Okay, someone's saying A, 22 meningioma. Yes, correct. What about B? CDKN2A? No. So CDKN2A, that was for a tumor that also had another one, but it had a worse prognosis with this specific mutation. Okay, it was the meningioma. Yes, correct. So the meningioma was associated with loss of chromosome 22, but it also had a TER promoter mutation or homozygous deletion of CDKN2A, which was associated with the worst prognosis. Okay. And I don't think you guys took C or E. Is this clear? Okay. Thank you guys so much for your participation. I really hope you enjoyed this session. Please scan this QR code to give us some feedback. If you guys have any questions, please feel free to email us or text us. We left our phone numbers on the first page.
Yep. And if you guys have any questions like right now, you can either unmute or send it on text, on chat. And thank you so much.
Thank you.